What are the limitations of RF application for PVI and IFE patients? We know that RF is a very efficient way of tackling PVI, but it is associated with some problems and issues. One is that it's time consuming, and this is why other techniques like cryoablation has become very popular. But there are other issues, and we will come back later to this time-consuming thing. The other issue that is safety is one of the problem of RF, and safety is mostly related to damage to collateral organs. And one of the collateral organs that is more risky is the esophagus. So atrioesophageal fistula, although it's a problem that is not so common because it's 1 out of 1,000 patients develop this problem, it can be a little bit higher in other cities, up to 0.8%, is a catastrophic complication. So most physicians, most operators try to avoid this complication by different ways, by monitoring esophageal intraluminal temperature or other ways. And one of the most popular ways trying to avoid this complication is by reducing power. However, if you reduce power, you need to extend your application time. And at present time it's unclear if this results in less lesion or more lesion. So this is something that needs to be clarified, and this is why we were involved in a program of research trying to clarify this thing. High power short duration RF application is becoming more hot topic in the EP. We have conducted this since I think I would say 2 or 3 years now. And one of the advantages is that the most obvious advantage is that you shorten the procedure, because each application time is less than half the time needed for a conventional application of 30 watts. So this is the most obvious advantage, but there are other advantages. The other one is safety, and this is a little bit counterintuitive, because you expect that if you apply more power, you will have more risk. But the equation of the size of the lesion is not only related to power. Also in the equation is contact and time. So if we look for analogy, it's like when you are trying to cook a steak. You use low power, so you use your fire in a low level. You need a standing time, and you will have a very tender but fully cooked steak. However, you want a middle of the steak a little bit raw. You need to have a high power of your fire for a short time. So with the heart is something similar. And what we are seeing is by using high power and shortening the time, we are getting rid of lesion. In fact, in the abstract that we presented, or we are going to present during this Congress, is what we found. In the conventional group, we found up to 30% of patients with esophageal lesions, but in the high power, especially in the extreme high power short duration, we had no patient with esophageal lesion. So this is a clear advantage of the technique. How to implement this in your routine? Yes, of course, we can recommend to you start using our technique, but I think it's too early. We need to validate our results in a randomized trial, and it's in the phase that we are now. However, being said that, it's true that we have had no patient with esophageal lesion. So from the safety point of view, it's very reassuring. So even if you are not using the same amount of power that we are using in this research, I will advocate to increase a little bit your power, and especially not to extend your application time, because what we have found is that the longer you apply in the side, the more chances is that you start inducing collateral damage, especially in the posterior wall. So this is one lesson that we have learned. The other is that if you are applying the posterior wall and you have a catheter dislodgement, and this is something that often happens with conventional application, because you have extended application time, so the chances of having your catheter dislodged for deposition are high, it makes sense not to go immediately to give another burn, on the same spot. It's better to stop, because otherwise you have a kind of double application on the same spot, and this is when you start having risks.